Good afternoon, everyone, and welcome to our webinar today. Today, we will be talking about hospital hybrid measure data collection. I am Peggy Ullman. I'm the Program Director for Quality and Transformation at CRISP. And then I also have with me Kristen Beatson, who is the Vice President of Electronic Measures at Medisolv. She will be speaking after me. And then we will close out the webinar with Diane Feeney, who is the Associate Director of the Quality Initiative at HSCRC. Couple housekeeping items before we get started. Just note that this webinar is being recorded, so if for some reason you are not comfortable with that, you can feel free to leave the webinar at this time. The recording will be made available at a later point in time to the registrants and will be posted on the eCQM section of CRISP's website. All questions will be answered at the end of the webinar. However, feel free to type in the chat whatever questions you want answered, but know that we will wait until the end of the webinar to answer those questions. During the Q&A at the end of the webinar, if you would like to speak, please raise your hand and you will be unmuted to ask your question or ask a follow-up if the answer provided wasn't sufficient. So if you could go to the next slide now. So I wanted to give a little bit of an overview of this digital quality measures project that we have in Maryland. HSCRC, CRISP, and Medisolv have worked collaboratively since 2021 to collect hospital eCQMs. For the 2023 data collection, which is occurring right now, HSCRC is requiring submission of the core clinical data elements called CCDEs for hybrid measures. Today's webinar is focused specifically on the data collection for the hybrid data elements related to the two hybrid measures currently required: the hospital-wide 30-day readmission, the hospital-wide 30-day all-cause risk standard mortality measure. It is not going to focus more generally on the eCQMs. There are lots of materials on our website about what the eCQMs are and what the requirements are. Next slide. So eCQMs are submitted via QRDA1 infrastructure that is uploaded to the Medisolv Encore portal via the CRISP HIE portal. The portal is now open from 1/15/24 to 3/31/24 for Q4 2023 eCQMs, as well as Q3 23 and Q4 23 hybrid measured data elements. For detailed information on the requirements and specifications and other deadlines, please visit the CRISP HSCRC digital measures page on CRISP's website. Next slide. Okay, now I'm going to turn it over to Kristen Beatson, and she is going to give us a very thorough review of hybrid quality measures from the perspective of what CMS requires. And then later, Diane Feeney is going to talk more specifically about how we are applying the hybrid measures specifically in Maryland. So thank you, Kristen.
Thanks, Peggy, and thanks for joining, everyone. So like Peggy said, we're going to talk specifically about the hybrid quality measures. I will be reviewing the requirements for the CMS measures, which are the same specifications, same requirements from a data collection perspective as there are in place for the state of Maryland. So next slide. So I want to start with what is a hybrid measure in case you're not familiar and this is the first time you're hearing about this, or maybe you've heard about hybrid measures and aren't quite sure what they are. The hybrid measures use claims data and EHR clinical data, combine that data, merge it together to come up with a measurement, the hybrid measure. There are two hybrid measures, as Peggy mentioned, the mortality and the readmission measure. So the data that you're collecting or that is being submitted in your claims and the data that we'll be mostly talking about today, your EHR data that will be submitted, will be combined to come up with those hybrid risk-adjusted mortality rates and the hybrid risk-adjusted readmission rates. The intent of the hybrid measures is to use that clinical data that you're collecting at the time of treatment that accounts for the severity of illness of the patients that you're treating, rather than relying solely on the data from your claims. So that clinical data that you're collecting is going to better account for how sick your patients are. And that is really the intent of all of the new data collection that you're doing for these hybrid measures, or not new data collection, but the data collection and the submission of that data. Next slide. So your claims data, I know many of you are familiar with this, but just a quick review. Your claims data is collected and submitted for every patient encounter, includes demographic data, admission and discharge data, diagnosis procedure codes, and billing information. Next slide. And then that claims data is combined with that EHR data. And this is really what's new with a hybrid measure. You've been doing claims forever, but what's new to create the hybrid measurement for the mortality and the readmission rates is the submission of the electronic data. So the vital signs and labs that are documented in your EHR currently, so captured electronically currently, are specified for these measures. And those data elements are called core clinical data elements. So you have specifications for your hybrid measures, just like you do with eCQM. So if you've been involved with eCQMs, maybe you've seen an eCQM specification. It has metadata and CQL logic. It has value set references and data elements. There are specifications for these two hybrid measures as well. And those specifications include all of the same things. It looks exactly the same, but the big difference is that in and of itself, those specifications for the hybrid measures is not a measure. It is just a guide for us, for you, to know what data needs to be collected, how you should collect it, how you should map it, and to guide in the extraction of that data, of those CCDEs, your labs, and your vitals from your EHR into the QRDA file for submission. And then those CCDEs are going to be linked with the claims data to risk adjust the measures. Next slide. And so I mentioned they're going to link this data, they're going to merge it together. And how they do that is through linking variables. The linking variables are a part of the claims data and a part of the EHR data, and they need to match. There are 6 linking variables that should be in the claim, 6 linking variables that should be associated with the patient, the encounter in that EHR CCDE file data. And that is how they link the claim for that encounter with the patient data in the QRDA file, those CCDEs that are associated with the same patient. They link those together and they come up with that measurement as a part of that process. Next slide. There are 6 linking variables. For CMS, it's the CCN, the MBI, the patient's date of birth, sex, and inpatient admission date, as well as the inpatient discharge date. So you have to have all 6 of those present in the QRDA files for every patient encounter in order for that link to occur to the claim. If any one of those is missing on the CMS side, they will not be able to link that data, that CCDE data, to the claim, and the patient won't be considered in the evaluation of the data. Next slide. So let's talk more about the core clinical data elements. Next slide. As I mentioned, there are specifications for both the hybrid mortality and then a separate spec for the hybrid readmission measure. The specifications include logic and initial population, value sets, CCDEs, linking variables, and supplemental data. I should mention that because this isn't a measure as you're collecting the CCDE data throughout the year in preparation for reporting this back, there is just an initial population. The measure specification doesn't have a numerator. There are no exclusions as based in the specification itself. All of the exclusions, if you're familiar with what CMS is doing with the hybrid measures, and maybe you participated in the voluntary reporting years previously, All of the other details, there are some exclusions, like if the patient expired, those are applied after the claim is received, after the QRDA file is received by CMS. So within the CCDE data collection process, there's truly only that initial population and then the evaluation of those patients to see if those CCDEs were available to them. Next slide. So the core clinical data elements that you're collecting reflect the clinical status. When the patient first presents to the hospital for treatment, emphasis on first. We'll talk about timing a good bit in today's discussion. The timing of the documentation is critical to whether or not the data gets included. We're looking for that first instance of documentation on the CCDEs. It's data that you're capturing already in your EHR and can be easily extracted from your EHR for reporting. Next slide. So let's talk about the readmission measure first. There are 13 CCDEs that need to be included for the patient encounters within the QRDA files for submission, and they're listed here. Vital signs, you can see all of your standard vital signs in addition to weight. And then the lab test results, there are 7 lab tests that are evaluated for the readmission measure. Again, your goal is going to be to try to include all of these elements for every patient that is seen in the inpatient setting at your hospital. The more data elements you have, the more accurate the severity of illness can be evaluated within the CMS calculation process for the hybrid readmission measure. Next slide. So I talked a little bit about the population and that the measure specification just includes an initial population, no numerators, it's just the initial population and then the CCDE and linking variable data collection. So your initial population for the readmission measure is any patient 65 years and older with an inpatient encounter length of stay less than 365 days. They have to be a Medicare patient. And I want to be clear on this piece. The reporting year that we're in right now for the hybrid measures runs from 7/1/23, so this past July 1st, and will end June 30th of 24. In that data collection period, that time frame, it's just referencing the logic, only just references your Medicare fee-for-service patients. Starting 7/1/2024, the beginning of the next hybrid reporting year for CMS, you will be adding Medicare Advantage to the Medicare population that's evaluated for these measures. So that is new for starting next year. This year, right now, the data collection period you're in, it's just Medicare FFS, and starting July 1 will be Medicare FFS and Advantage. And then also including patients that patients have to be discharged during the measurement period. So if a patient meets those qualifications, they will be in the initial population for this measure. And then the evaluation of CCDEs takes place. So identify the patient population, and then from those patients and encounters, evaluating whether or not those CCDEs were present. I mentioned timing. Timing is key to the data collection. It's also one of the reasons we see gaps in this data, and one of the things that you should consider if you're trying to improve the data collection for the QRDA files. So the CCDEs are based on timing, the timing requirements listed here. It is the first instance of documentation that meets these requirements that's going to be included. If there's no documentation that meets these requirements, then nothing gets included in the file. So when we're talking about labs and vitals, the first kind of timing window looks at 24 hours before the start of the inpatient encounter. Any of those labs and vitals that are documented in the 24-hour period prior to the start of the inpatient encounter will be evaluated, and the first instance of documentation will be included in the file. So the patient comes in through the ER and you have, and then gets admitted, and they had 2 temperatures documented during the emergency room stay. That first temperature is what's going to be included in the file. The timing continues and looks for vitals only 2 hours after the start of the inpatient encounter. So capturing your direct admissions any vital signs that are documented within the first 2 hours after the start of the inpatient encounter will be evaluated, and the first instance will be included in the file. And then the last one is your labs and weights. You have a 24-hour window after the start of the inpatient encounter to get that documentation done. That first instance of documentation and any first instance of labs and weights that happen within the 24 hours after the start of the inpatient encounter will be what's included. So it's any one of those. If they come in through the ER and they have their weight documented in the ER, and that's the first instance, and it's within 24 hours before the start of the inpatient encounter, that's what will be included in the file. So timing can be tricky, and we'll get into it a little bit. We'll talk a little bit more about it, but mapping of the data and timing of documentation are the two main reasons that we see gaps in CCDEs and the hybrid data that is being evaluated for submission. Next slide. So as you capture or think about capturing this data, thinking about how you're capturing it currently, and I'm going to make the assumption that you're all capturing this data already. The first piece is making sure you're getting all of the data for the initial population for the measure. Your inpatient encounters are already mapped for your standard eCQMs to SNOMED codes, and so that data should be populating and already being evaluated for this measure. And then you have your Medicare FFS, making sure you have all of the source of payment codes mapped to capture those Medicare FFS patients correctly. And then you don't have to worry about the Advantage patients right now, but starting 7/1/24, you do. So once we get to July, you want to make sure that you have all of the mapping in place to capture that Medicare Advantage source of payment code. And then once, again, that initial population is identified, then you want to make sure you're capturing all of those CCDEs. And I know this is documentation you're doing already, but making sure that all of the vital signs that you're capturing within your hospital, within the health system, are mapped to the LOINC codes. And again, you may have different processes for capturing this data, different fields for capturing, heart rate. Maybe you have one field for documenting in your ICU versus in your ER, making sure every instance of this documentation is mapped to the correct code so that you can capture it regardless of where they enter your hospital. It's that first instance. So we've had, with the hospitals that we work with, we've had patients data, CCDE data come in from outpatient labs because it was done within 24 hours prior to their inpatient admission. So make sure you're thinking about all the places that you're capturing this data, all of the clinical documentation, and making sure it's mapped. Same thing with labs, making sure all of the labs that are associated with the data elements here are mapped. Making sure you have the correct LOINC code associated and that you're reviewing the value sets and all of the different types of tests that are included in those value sets so that you have them mapped correctly. Next slide. The mortality measure is pretty much the same, just a couple slight differences. It has the CCDEs, but in this case, the mortality measure only has 10. So there are fewer CCDEs, fewer vital signs, fewer lab tests. But on the lab test side, platelets was added. So you do want to make sure you have your platelets set up for the mortality measure and that you have all of the mapping in place for that and that that data is being captured correctly. Next slide. And again, very similar. I'm not going to go back through all of this. The same timing applies. The population is the same except for the age range. For the mortality measure, the age is looking for patients 65 to 94 years. So you will have different initial populations for this measure. If you're tracking it in an EHR report or some other report that you have, or maybe you're using our Encore application to look at these results, most likely you're going to have different populations for your readmission measure versus the mortality measure. So you want to keep that in mind when you're looking at those results, that those populations will be slightly different, most likely. Next slide. So again, Similar setup. Typically, once you have everything set up for the readmission measure, which came first in all of this, the hybrid readmission measure was the first, and then CMS later added the mortality. So no differences in the way you're setting up your initial population. The only difference, as I mentioned in the CCDEs, is you want to make sure you account for the platelets, which is not in the readmission measure, but is in the mortality measure. So making sure you have all of your platelet tests mapped to the correct LOINC code so that those results, so the test and the results can be captured for submission in the QRDA file. Next slide. So that's basic overview of the CCDEs, the measures, and kind of that process of getting all of that data mapped and setting it all up and making sure you have it correct in the EHR data collection process. Once you have all of that in place, you want to be able to look at your results, right? You don't want to submit this data blindly. It's helpful to be able to make sure you're capturing your initial patient population correctly and that it aligns with what you would expect your Medicare population to be, and that you're capturing all of those CCDEs and linking variables in preparation for submission. So you want to be able to review that data collection, validate it, improve upon it, hopefully fill in any gaps in advance of submitting the QRDA files to the various agencies. Next slide. And so CMS has specific thresholds that you have to meet for linking variables, for labs, and for vital signs. So when you submit your data to CMS, they will indicate in your hospital-specific reports that you get typically the following spring, if you met the requirements for each of these categories. We learned a lot about these this past year. The first voluntary reporting year HSRs were published, and the calculations were different than many of us expected. So we asked a lot of questions of CMS, tried to get some clarification on what meets and doesn't meet the requirements for the hybrid measure. And that's just what I want to talk about in advance of talking about, the validation and improvement process. This is important to making sure you meet the requirements for CMS. So all 6 linking variables must be submitted for 95% or more of qualifying encounters to meet CMS's requirement. 90% or more of qualifying encounters have to have all of the vital signs, and 90% or more of non-surgical qualifying encounters must have the lab results. Surgical hospitals must submit the data if it's available. So there isn't a true exemption for surgical hospitals. They want you to submit data if you have that data available. Next slide, and I'll explain this a little bit more. Again, I expect us to learn even more once the next set of hospital-specific reports are published by CMS. So it's a bit of a learning curve for all of us. But from what we understand and what CMS is basing the met, not met on for each of these categories is at least 95% of your encounters must have all 6 linking variables documented and included in the QRDA files. So when you're looking at your patients, your goal should be to have all 6 of those linking variables for every encounter in the file. But we know things happen, and sometimes things are missing, or maybe there's a typo, and it can't be evaluated by CMS. You want to make sure you're staying in that 95% or higher range. And when you're looking at your data, any patient with 1 or more linking variable missing, you would consider that that patient fell out, did not meet the requirements. So as you're looking at your results and you're analyzing how many patients are missing, you want to look at your overall, how many patients were missing at least 1 linking variable, and then do that math. So if you have if you have 100 patients in the IPP and 20 of them are missing at least 1 linking variable, you're going to be at 80%, and you will not meet requirements for the linking variable portion of the measures. Same for lab results, except the number is a little bit lower. You have a little bit more wiggle room there. At least 90% of encounters must have all required labs resulted within that logic timing. Keep that in mind, and included in the QRDA files. So again, when you're looking at your labs and then vital signs, it's the same, making sure that at least 90% or more of your patients have all of the vitals, all of the lab results. Any patient missing one, it goes into that did not meet category and will impact your overall numbers and your ability to meet requirements for both labs and vital signs. Next slide. So as you're considering this and hopefully have some options to look at your data throughout the year, throughout the quarter, in advance of submission, you want to consider several things when it comes to validating that data and improving that data. The first thing is your measures, specification, the logic, sometimes the data elements, definitely the mapping requirements and codes change every year. So every May, a new version of the specification, a new version of the value set, new versions of the value sets are published. And you want to make sure you're keeping up with those changes, make sure you're working with your EHR vendor, your reporting vendor, internal resources to make sure you have all of those mapping and updates in place for the next reporting year. Timing I've talked about, that is a big reason for missing data. If the wait is done 3 days after the patient's admitted for the first time, that patient's data is not, that wait is not going to be included. So making sure you're meeting the timing requirements for each of the data elements, each of the CCDEs that are included in the measure specifications. Capturing that documentation across the health system, I talked about that a little bit. Regardless of where you're documenting your vital signs, just make sure it's mapped. That's the easiest way to make sure, regardless of how that patient comes into your hospital to become an inpatient, that you're capturing that first instance of documentation in a timely manner and accurately. You want to make sure you have a method to track the presence of your linking variables, vital signs, and labs for all of your patient encounters to make sure you can understand where you're missing data, why you're missing data, and start improving upon that. Sometimes there's errors in documentation that we come across that need to be edited or addressed from an educational perspective. Workflow gaps can impact data collection, as we know. Units of measure are not to be ignored. They tend to cause a lot of issues with the hybrid data, the CCDE data evaluation upon submission to CMS. If the unit of measure associated with the documentation with the lab result is not in their acceptable units of measure list, they won't evaluate that data. It gets kicked out. So you want to make sure you have the correct units of measure on all of your vital signs, all of your lab results. And then if all of this is being monitored and improved upon, it's really just compliance and trying to make sure that documentation is happening correctly and in a timely way so that it is included in the QRDA file. Next slide. Just a quick view if you're not familiar. I mentioned the annual measure updates and value set updates that are released every May. This is just an example of a couple screenshots from the top portion of the readmission measure, and you can see they look very similar, but these measures have been updated. The top one is for this measurement data collection year, and the bottom or the middle screenshot is for the collection year starting 7/1/24. And you can see the measurement period is listed on there, and there's an updated version number. So you want to make sure, again, that someone is tracking these updated versions and you're accounting for any changes in the measure specification for the upcoming reporting year. Because codes do change. So if a LOINC code for temperature changes, you will need to update that code in order to make sure you're getting that temperature data into the files and into the data collection process for submission for these measures. And then the very bottom, if any of you are responsible for the mapping piece of this and for monitoring the codes and the codes changes and mapping on the back end in your EHR, this bottom screenshot is from the Value Set Authority Center website. That is the go-to for all value sets associated with all measures, eCQMs, and your hybrid quality measures. So you want to make sure someone that you're working with on this has access to VSAC and access to pull that data every year when there is an update to those value sets. Next slide. We summarize for our integrated clients all of the changes for each measure, and this is just an example for the readmission measure. You can see a lot of changes on here in preparation for the 7/1/2024 start of that measurement period. So again, just making sure you're aware of all the changes that are coming from year to year with these measures, as well as your eCQMs. It's the same process. It's just a lot to keep up with. And I wanted to mention, because definitely if you don't have the new mapping in place, you may see missing data in your CCDE data for submission within those QRDA files. Next slide. I'll mention timing again. When you're looking at your data throughout your reporting year in preparation of submitting that data, make sure you're looking at if something is missing from the data collection for the hybrid measures. Make sure you're looking at the date and time it was documented and comparing that date and time to the date and time of inpatient admission. Again, mapping tends to be kind of the initial #1 reason for missing data in these CCDEs, and then the timing tends to be the next reason. If it's just done outside of these timing window requirements, it won't be included in the submission. Next slide. So as you start thinking about this, I'm assuming you all already have been thinking about this, you want to make sure you have a method to review those results in advance of submission. So hopefully you can improve upon them, or at least understand where the gaps are and why they're occurring. Currently, for the hybrid measures, in order to meet your Maryland requirements, you're going to be uploading those through the Medisolv submission portal. So just a quick screenshot of that for reference. Next slide. And then once you submit that data through MSP for the hybrid measures, it is published to Encore. I think everyone has access to Encore, or certain people at each of the hospitals. Within Encore, you can see your hybrid measure results. There's a hybrid measure tab, and within that hybrid measure tab, you can see the details of the initial population. That's the screenshot at the top, for both the readmission measure and the mortality measure. So you can see how in this example, those initial populations are slightly different because of that age difference in the initial population for the mortality measure. And then the bottom screenshot, again, from Encore, shows you all of your missing CCDEs. So this is really what you should be looking at, or something similar, so that you know how many patients are missing weight documentation. In this case, in this example, there's 767 patients in the initial population, and then 58 of them are missing weight. So you want to be able to understand how that impacts your data. And that missing percentage is 7.6%. So it's kind of getting up there in the percent missing, and want to be able to drill down, look at that data, understand the patients that are missing that weight, and start to do some investigation around improvement. Next slide. And within Encore, you can drill down and see those patients. You can see any patient, their documentation for each of the CCDEs, and then where there are gaps. So again, if we're talking about weight, you can see the patients that are missing the weight, all 58 of them, and you can go through the patients and look at, was it truly not done, or was it just done after the timing requirement, or maybe there's an issue with the mapping for that. Sometimes, I gave the example earlier, sometimes everything gets set up and then you find a different area where weight is captured that didn't get mapped, and it just needs to have that mapping put in place, and then that data can populate, and you can have more complete data for submission. Next slide. So before I turn it over to Diane, I just wanted to mention that, the reason you're doing all of this is because, as CMS has said, the best performing risk adjustment models assess the severity and the comorbidities of the patient. Claims-based models assess the burden of the comorbid condition, but the clinical data really provides that better measurement of the severity of illness for which the patient is admitted to your hospital. So making sure that your CCDE data is complete, is accurate, includes all of the data that was documented for that patient within the timing requirements is really important to increasing the accuracy of the results that you're going to get back. So CMS is going to provide these hospital-specific reports to you after you've submitted the data, after they've done all of the linking back to the claims data, and they have their calculations that they run. They are going to provide back to you a hybrid risk standardized readmission rate and the hybrid risk standardized mortality rate. And hopefully that data is useful to you and can be referenced for understanding those rates within your hospital and how you can make improvements moving forward in using that data. So with that, I am going to turn it over to Diane, and I think you can flip to the next slide. And she is going to talk about the hybrid measures for Maryland.
Yes, what I would like to do, though, is take an opportunity to look at the questions that are specific to your presentation, and maybe they can we can have some answers at this point. One of them from Tom O'Neill: should point of care testing for labs, i.e. sodium, creatinine, be considered for the hybrid measure?
Yes, any lab, regardless, point of care, any of these lab tests, wherever they're done, if it is a lab test that is listed as a CCD, yes, they should be considered.
Okay, great. The next one is, do you know about who is excluded from whether patients transferred in from another facility are excluded?
I believe, I know there's a transfer exclusion. I can get that data. And I don't know, Peggy or Diane, if there's a way to get this data out to everybody, but I can follow up and get this. I can get a full list of the exclusions and share those.
Great.
Because those exclusions aren't applied within the QRDA file, I'm just not as familiar, but I can pull that from one of CMS's presentations.
Great. Also,
you can send that to me, Kristen, and then when we send out the webinar, we'll include, we'll include a link to whatever it is you send as follow-up.
And then there's one last question, and I can turn my camera on.
You have it on.
Whether all payer is the same as Medicare Advantage. And the answer to that is no. So thank you, Kristen, for your really informative and thorough presentation on the hybrid HWR, HWM measures. Peggy, are you seeing my video?
Yes.
Okay, great. So this slide just simply illustrates that Maryland's requirements are currently aligned with those of CMS. Further, as hospitals are aware, just as an aside, all Maryland hospitals must comply with all of the CMS IQR and OQR reporting to CMS, as well as the reporting requirements set out by the commission and the state. You see on this slide, case mix is put in instead of claims data. So Maryland's version uses case mix data, which mirrors what is in the claims data set to Medicare. And then these other data elements are the same as what CMS is requiring. We can go to the next slide. This slide provides an overview of HSCRC's interests and goals that we want to achieve using digital quality measures. CMS has signaled by the end of the 2020s, they fully expect a fully digital quality measurement enterprise across the health system. That may be idealistic, but we do know that the goal is to really evolve toward that and ultimately reduce the burden and stress of collecting this data and have it be more of an automated function. Although we know that implementation is not quite as ideal as what they want the end result to be. To leverage this move to digital reporting, the state has established statewide hospital infrastructure, as was mentioned earlier. And we started a pilot in 21 and then required submission beginning in 2022. Maryland's all-payer programs have, for instance, targeted hypoglycemia eCQMs, and asked all hospitals to submit them because we believe those measures are aligned with our goal to improve care for patients with diabetes. For obstetric morbidity and mortality rates, we last year required hospitals of birthing facilities that we do require submission, and this is aligned with the CMS submission requirements as well now. And it's important because we have high rates of SMM, and further, we have high rates of disparities for that measure. So we definitely have statewide goals to reduce those, and it's included both diabetes care and severe maternal morbidity in our state integrated healthcare improvement strategy. So it's a statewide effort. So turning now specifically to the hybrid HWR, HWM measures, as mentioned, the requirements are aligned with CMS. However, we did, as of July 1 of this past year, notify hospitals they can participate in a pilot if they so choose to open the parameters of the measure and not just include Medicare fee-for-service, but include all payers as well as patients aged 18 and above for these measures. We have, as far as we know, 2 hospitals that chose to participate in that pilot for the purposes of submitting data to Maryland for the first year, while other hospitals have not notified us, but we may presume that they are submitting Medicare-only patients according exactly to the CMS specification. A fundamental tenet under our total cost of care model and the quality programs here in Maryland is to be agnostic to the payer and to have all patients hospitalized within the state have the benefit of the quality programs that we have established and implemented. So to that end, our goal is really to shift to receiving hybrid HWR, HWM measures beginning in July 1 of 24. And these measures would be expanded to all payers. Go to the next slide, please. So here we just review what Kristen has so eloquently described. The CCDE for Medicare fee-for-service for HWR is for patients 65 and older, whereas the HWM measure has a top end at 65 to 94. And CMS is requiring the July to June, beginning in July of 24 on that data. Maryland is aligned initially with the CMS, but the only caveat is that we're asking hospitals to submit their first 6 months of data, July 1 to December of 23, beginning now during the submission window that Peggy mentioned earlier. So beginning in July 1 of 24, again, we want to expand these measures to all payer and are requesting submissions. In Maryland, also, just as an added detail, hospital-wide mortality measures to calculate them require matching with the case mix data with the vital statistics death record. So that's how we will derive that measure, since we don't have the CMS enrollment file, which is, I presume, what they use to do the matching. We can go to the next slide. So this just shows just a very easy schematic of how the data is submitted. CRISP receives the eCQM data and the CCDE via Medisolv. It must contain the facility RN, MRN for the patient and the hospital ID so that we can match it with the case mix data, and then we can derive the patient master patient index and the unique patient ID so that we can track a particular patient across the system. So those are data elements that have to be submitted with the linking variables and the hybrid clinical data elements. Then at the end, HSCRC links the data with case mix. So we can do more robust analytics around things, again, like disparities that we may find in care. The ultimate goal of these things is potentially for public reporting. We have our MHCC sister agency, and they report important quality data to the public. And so this data, the opioid use eCQM, for instance, will go in the summer of this year on the Maryland MHCC public reporting website. Ultimately, we may, because as Kristen described, this clinical data really makes or illustrates differences in patient populations and provides the opportunity for much more robust risk adjustment. Therefore, would be a fairer way to compare performance across hospitals on these clinical measures. And we at HSCRC believe that fairness is extremely important, particularly when you're talking about potentially linking to pay for performance as we go down the road in a couple of years. So we can go to the next slide. And so I'm not going to read these, but here are the submission windows for the timeframes for each quarter for 2023 and 2024. And I don't know, Peggy, if there are questions. This slide just lists a list of linkages to many of the resources, the CMS, HWR, HWM methodology papers, which probably could talk about the transfers. And then there's the Maryland specific resources, as well as CMS and more national resources on this slide.
Okay, great. Thank you, Diane, and thanks again, Kristen. We do have some questions in here. I think a couple of them are for Kristen to answer, and then some of them may be more specific about state policy. So Delia is asking, the Encore reports show each element's percentage that are missing, but not the overall percentage for the qualifying encounters, having 90% of all of sorry, I'm having trouble with my mouse, to having 90% of all of them captured. Is there a way to get the overall percentage for the encounters to know our performance?
We're adding it. Can you hear me okay? We're adding that to the reports. Hopefully it will be in there by the end of Q2. I don't want to give an exact date because these things take time and things pop up, but hopefully by the end of Q2, we will be adding those additional reports to give you that overall met, not met. Understanding though, once this data is submitted, and additional exclusions are applied by CMS, and they, are working their magical calculations, we don't expect it to align exactly, because we're not performing all of those exclusions and all of that, because it's not within the specifications. But it should give you, and what's in there now and what will be added should give you an idea of where those gaps are and what you need to address. So coming soon.
Great. And then there was a question about, so you are not requiring all payer in 24, 25. So I think it might be helpful, Diane, to review the timeline of when when the state of Maryland is requiring just Medicare, and then with the option to do all payer, and then when you are officially requiring all payer.
Yes, so sorry if I was confusing, and I will restate it in a way that hopefully will be clearer. HSCRC initially had asked that hospitals submit all payer beginning in July of 23. We adjusted that requirement and asked that hospitals just comply with the Medicare requirements from July of 23 till June of 24, with the exception of submitting the first 2 quarters of data early in this January timeframe that we are now in. So it's the same as Medicare requirement, but moving up the first 2 quarters. As of July 1 of 24, we are asking that through June of 25. We are asking that for that time period, hospitals begin to report patients from all payers and those aged 18 and above.
And that's the reporting begins in July. I mean, the date time period is beginning July, but the actual
Reporting begins in January of 25.
Right.
The performance period begins in the discharge as of date begins July 1 of 24.
Great.
And so there's a request about the specifications, and I would refer you to the CRISP website. It's one of the resources on the page before this last page here.
Yes, I was trying to find it, but then so I can put the link to the page, and then you have to scroll about halfway down the page to find the hyperlinks to the requirements. So let me put that in the chat. While I'm doing that, Nicole is asking about, she said, we are seeing a number of patients who fall out. Sorry, I'm again having trouble with the scrolling. Falling out with weight because it is sorry. They're falling out with weight because it is documented when they're in the ED, and then they are made observation patients, and once they are changed to inpatient, it's been more than 24 hours. Has anything been discussed about a workflow where they are not double documenting a wait?
I know we had heard about this from some other hospitals that depending on how long they're in the ED for, how long they're in observation, that documentation will fall out of the timing requirements, or that falls out of the timing requirements and or that initial data capture isn't necessarily the first instance of documentation. So there is a ticket open with JIRA, if anyone is familiar with that they are, I guess the measure developers are looking at updating the logic starting 7/1/2025. So year and a half, right? Or yeah, year and a half to include the a change in the logic so that data could be captured. So I don't know if there's, from a workflow perspective, any way to address it. But from a logic perspective, it is what it is until, we're kind of at the mercy of those measure updates. But it does look like there's quite a bit of feedback on this topic, and they're looking at updating the logic to capture that data. And I can share that in the chat if anyone wants to look at that JIRA ticket and provide their input on addressing that issue.
There is a note from Brandy that she's clarifying. She's looking for 2024 hybrid specs.
For the Medicare specs.
No, the all payer specs.
So they just the 2024 specs, I believe CRISP and Medisolv worked together to put those on the website. And we can circle back to
yeah, Brandy, if you could send me like a private email, like if you could send me a private message with your email, or you know what, I will, I'm actually going to put my email in the chat. This is for Jackie as well, who had the question about who is working at Holy Cross, and where are you guys in the process? I can, if you want to send me an email with your questions, I can track down what you need and get verification for everything. Is there any, sorry, there's one. The JIRA ticket for the issue with the data capture and OBS. Oh, sorry.
I just put that in. I just added that. Yeah.
Kristen, the only thing is I think you sent that just to the host and the panelists. You have to change your thing to everyone. And then if you could repost that.
I'll do it now.
Okay. Well, let me just check. I think that all the questions were answered. And then we can if we can hang on for one more minute to see if anybody has any last minute questions, but I'm impressed we got through all this information and all the Q&A in the hour, because it's very dense content. Both the slides and the webinar itself will be emailed. The webinar recording will be emailed to the participants, and please let us know if you have any additional questions or need additional information. And I want to thank our speakers, Kristen and Diane, today, and thank you everybody for making time to join us on this webinar.